Hello, everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to this, our third in a special series of NDUS Presents webinars highlighting global drug early warning systems. The NDUS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both are with us in the audience today. My name is Erin Artigiani, and Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are all part of the NDUS Coordinating Center team. For those who are interested, you can find detailed information about NDUS, recordings of our prior webinars, and invitations to future webinars on our website at www.ndus.org. You will also find instructions for how to join our NDUS network and participate in ongoing discussions with more than 1,600 experts and concerned citizens from across the United States and many other countries. The webinar today will feature Dr. David Newcombe, representing GDUs, and experts from South Africa and Nigeria, describing the methods used in their drug early warning systems, the challenges and successes they have encountered, and the lessons they have learned. Our colleague from Kenya, who was scheduled to be a part of this webinar, was unexpectedly called away, but we do have a copy of his slides, and we will make them available on the NDUS website for anyone who is interested. This webinar will be about an hour and a half to 2 hours long, depending on questions. And we encourage you to submit questions during and after each of our presentations. But please don't use the raise hand feature. We would like you to submit your questions in writing using the Q&A box. And we will be monitoring that, and we will get back to you with answers either directly from ourselves or answer your questions live over the course of the webinar. And if we don't get to all of your questions, we can also pull together a list of the questions and answers and post them on the NDUS website. So we will make sure one way or another that you get the information you need. And so thank you, and we hope that you enjoy our webinar today. And now I'm going to introduce, and I'm very excited to introduce Dr. David Newcombe, Senior Lecturer for Alcohol and Drug Studies at the School of Population Health and the Center for Addiction Research at the University of Auckland in New Zealand, and he will give you with an overview of the mission and goals of GDUs and then introduce our other speakers. So David, I'll pass it off to you.
Thanks, Erin, and greetings and a very early morning from New Zealand. I'd like to welcome everybody to the third webinar in the series examining global drug early warning systems. Today, as Erin was saying, we are focusing on some drug monitoring systems located in Africa. What I'd like to do with the time I have is just to give you a bit of an overview of the global drug early warning system. So a team of us in New Zealand, some of us from the Centre for Addiction Research at the University of Auckland and other institutions, have been working at scoping a New Zealand drug early warning system. And this led to some collaborative work with the team at the Centre for Substance Abuse Research at the University of Maryland, and so Global College Park. And so part of this was to submit an application to NIDA for a Distinguished International Scientist Award, or a DISCIRF, that would allow me to work with the team at CESAR to examine drug early warning systems. The main objective of this project, which we've called the Global Drug Early Warning Systems, or GDUs, is to examine existing drug monitoring systems from around the world to gain an understanding of how they work, the context in which they work, and to get some idea of what they consider is areas of best practice. So the primary goal of this project is to develop some guidance that's being utilized by these systems to help support countries establishing their own new drug early warning systems. We have a number of outputs or products, the main one being the webinars that you, this one here we're looking at, particularly focusing on Africa. And in these webinars, this webinar series, we're asking representatives from different early warning systems around the world to talk a little bit about how their system operates and the context in what they do and a few lessons learned. So the products are, in addition to the webinars, a series of written articles. But as I said before, the main product is this resource on best practice and guidelines for setting up drug early warning systems. So we have got some interesting and very exciting speakers lined up for this webinar. As Aaron was saying, unfortunately, the speaker from Kenya was unable to talk to us today, but we do have his presentation will go on the website. But I'd like to hand over now to Dr. Nadine Burnhams, who's a senior scientist at the Alcohol, Tobacco and Other Drug Research Unit in the South African Medical Research Council at the University of Cape Town, to talk about their drug early warning system. So I'll hand over now to Nadine.
All right, so Nadine, are you getting on board? Okay, there we go. That looks good.
Good afternoon, everyone. Thank you, or good morning in other parts of the world, and good evening in, I suppose, some of the other parts of the world. Thank you for the opportunity to speak and being invited to speak on our projects that we run, and one specifically, Sekendo, which I will be speaking about just by way of an outline. What I will be looking at is just giving you a little bit of a background to South Africa, the alcohol and other drug use trends in South Africa as we currently see it, emerging concerns, data sources, and then Sekendo, which relates to early drug warning system, but also our treatment demand network that we run out of the country. And under point 5, Sekendo, I'll be touching on various processes that are involved and including advantages, challenges, and limitations. So just in terms of South Africa as our country, we've been referred to more often and not as the Rainbow Nation, and that is largely related to us emerging after 1994 as a Rainbow Nation. Prior to that, we like to say that we were in the dark days, but the dark days are over now. So just in terms of location, South Africa, or the Republic of South Africa, is the southernmost country in Africa. So we're right at the bottom of the massive continent that is Africa. And we are on the border. We have about 2,798 kilometers of coastline. If anybody wants to come visit, there's lots of beaches. And then we are bordered by Namibia, Botswana, Zimbabwe, and Mozambique, as you can see on the map. South Africa has about 56 million people and has been classified by the World Bank as an upper middle income country. But even though that is the classification, what should be highlighted, that poverty and inequality remain widespread in South Africa. We have about a quarter of our population that is still unemployed and living on less than, I put it in US dollars, 1.25 a day. Access to basic resources, including substance abuse treatment, still remain problematic for most people that are affected with any form of substance-related disorder. South Africa is a multi-ethnic society, and post-apartheid, after 1994, South Africa became or was divided into 9 provinces. The Northern Cape, and this becomes relevant for a little bit later, the Northern Cape, the Western Cape, the Eastern Cape, KwaZulu-Natal, the Free State, Northwest Province, Mpumalanga, and Limpopo over there. And that little orange spot is Gauteng, and that is where Johannesburg is, which most people would probably know, and Cape Town is right here at the bottom, and that is where I'm speaking from today. We have 11 official languages, and we have the second largest economy in Africa. I think my colleagues in Nigeria have the first, or ranked first. So just in terms of substance abuse and a bit of background again, post-1994, I mean, pre-1994, we were locked in the apartheid, and there were heavy sanctions on South Africa as a country. Post-1994, these sanctions were lifted, and the country itself saw an increase in illicit drug trade during that time. Before 1994, South Africa was an unsaturated market and became a saturated market following 1994. Initially, we had alcohol, marijuana, and methaqualone as our main drugs of abuse. In South Africa, and I think it's quite unique to this country, marijuana and methaqualone get smoked together and is referred to as white pipe, and is normally smoked in a bottle, a beer bottle, at the top part of a beer bottle. Since 1994, there's been a lot of moves and increases in research initiatives. And in fact, in his opening address in Parliament in 1994, our late President Nelson Mandela signaled that substance abuse was a major problem in South Africa, and he called for concerted efforts to address the growing epidemic. And since 1994, there's been a number of ad hoc studies, and these varied between descriptive, analytical, and intervention studies, and really just to start informing an evidence base. Just a brief overview. Alcohol is a primary substance of use in South Africa as a whole, followed by, of course, tobacco and cannabis. What we do see in South Africa is provincial variations in drug use, and that is our country over here. So in the Western Cape, which is where I'm based, methamphetamine is the primary substance of abuse, and what people actually seek treatment for mostly, followed by cannabis. But if you go to the top, and we have combined these two provinces, Limpopo and Mpumalanga, we have started finding heroin becoming quite a problem in those provinces. In the Eastern Cape province, again, as you can see, there's alcohol, cannabis, meth, but over-the-counter and prescription medications has over the years sort of put in an appearance, and it's also largely related to the fact that some of the major pharmaceutical companies are located in Port Elizabeth, over there on the very southern side. In the Northern Cape, these provinces that I'm circling are very poor provinces. The Eastern Cape is also a very poor province, so resources are very limited. Just in terms of lifetime prevalence of substance use disorders, unfortunately, South Africa doesn't have a dedicated alcohol and drug household survey that runs every few years, as is the case in other countries. But one survey, the stress, anxiety and stress health survey that was conducted a while ago, found a 13.3% lifetime prevalence of substance use in South Africa. And alcohol is also responsible for 7.1% of all deaths and 7% of all disability-adjusted life years lost in South Africa. Just some emerging concerns. Over the last 3 years, we have seen the emergence of what we call NAOP. Nothing new. It's just a cocktail of cheap, low-grade heroin that is mixed with cannabis and smoked. And it is very, very common up in the north, in our Gauteng province and in Durban. And it's beginning to get a whole lot of attention, particularly because of it's becoming quite widespread in the townships, because it is accessible, it is cheap, and people have easy access to it. It is really problematic in terms of treatment and for practitioners when it comes to treating, because these low-grade heroin mixed with cannabis sometimes even contains other substances that you are not aware of, or that the individual or the patient isn't even aware that they are taking in. So some research has been done to try and isolate what is in Nayopi. And they have found, or the results have shown, that it could be anything from antidiarrheals to ARVs to methamphetamine to, and of course, heroin and cannabis that are the main ingredients. And this is quite a problem. We've also had anecdotal reports about crocodile, which is this morphine. We haven't had much of it, but it's something that we're flagging. New psychoactive substances, synthetic cannabinoids, we know that there are global concerns. We have not picked anything up. There has been no reports coming through to the MRC where I'm based. We've had problems with methcatinone, but that has also stabilized over time. What we are seeing, however, is codeine abuse and other over-the-counter prescription medications such as methylphenidate use, which is used for attention deficit disorder, and it particularly used amongst university students at this stage, and also working parents or working mothers. Sorry. So just in terms of data sources, we are constantly in the process of improving the data that we get. Currently, our strongest system that we have is our Secendo system, which collects treatment demand data. And we have hospitals, but it's been very difficult to access our hospital data. Mortality, mortuary reports, those you get on an ad hoc basis. Again, it's a process that we are trying to work through. In the past, we did get police and forensic data on a regular basis, but due to political changes and issues related to top-level government departments, it's been difficult, and we get it, but sometimes at a time when 2 years has passed or something like that. Psychiatric data that we have access to, not for all hospitals, but generally for most. In terms of surveys, as I indicated, they are ad hoc national household services surveys, not dedicated to alcohol and other drug use. They would be the sort of the demographic and health survey that gets conducted every few years and may contain a few alcohol questions, but nothing on drug use. Then there's the stress and health survey that would look at substance use disorders perhaps as a whole, and not be specific about certain drugs of abuse. We have had youth risk behavior surveys run over a period of time, and the last was in 2011. It's unfortunate that we haven't had one since. And then naturally there are various community surveys and province-wide surveys that get done as funding allows. So out of just moving back to the previous slide, so what I'll be speaking about is our treatment demand data. And that is what we call the South African Community Epidemiology Network on Drug Use, or Secendo. It was established in 1996, which is 21 years ago, so we've been celebrating our anniversary. And Secendo is an alcohol and other drug sentinel surveillance system operational in all nine provinces of South Africa. It monitors alcohol and other drug use and associated consequences on a 6-monthly basis from specialist AOD treatment programs and people admitted. It's modeled after the drug surveillance systems established many years ago. One of them is the US Community Epidemiology Work Group, and was started by the South African Medical Research Council, which is the organization I work for, under Professor Charles Parry. He was initially involved in it, along with Nick Kazal and Arvind Bana from the University of KwaZulu-Natal. Initially, Secendo was funded by the World Health Organization, but now it's funded by the National Department of Health and the SAMRC. Excuse the spelling error there. So what are our objectives? It's to establish a network of researchers, practitioners, and policymakers, identify changes in alcohol and other drug use trends and even emerging trends, any changes in negative consequences related to alcohol and other drug use, inform policy planning and advocacy efforts, stimulate further research into new and under-researched areas, ensure participation in international and internal and international fora, and facilitate completion of the UNODC ARQ in South Africa. As I indicated, Secunda provides data on treatment demand. It's operational in the 9 provinces. At the moment, as I sit here, we have approximately 80 treatment centers. Those are centers that a person afflicted with a substance use problem could go to for treatment. The Secunda network covers approximately 80% of the treatment population and 75% of treatment centers or specialist treatment centers. We are in an ongoing process in recruiting more, but because Secunda is voluntary, we cannot force centers to join. These centers includes those that are state-funded, private, and as well the non-governmental organizations. And we see about 10,000 people in treatment every 6 months, or the data we collect are for about 10,000 persons. All our treatment centers located within a given site or a given province we are normally notified of a center going up, and we make contact with them, ask them if they would like to join the network, giving them information. Of course, it is voluntary, so they are not forced. And then now given the Secunda data collection forms, but they also undergo either telephonic or a face-to-face training on how to complete these forms. It depends on whether the person or the treatment center is local or a little bit far. The country is quite vast, and so we can't travel up and down. These specialist alcohol and other drug treatment centers tend to be more urban-based. So you'll find Gauteng province, GP, and the Western Cape, which is the province that I'm in. There are a lot more specialist treatment centers there than there would be in other provinces. And the challenge that we have is access tends to be biased towards still the white and mixed race and Asian South Africans. And then we have a lot of private centers that have popped up over the last a couple of years, private substance abuse treatment centers, and they cater largely for foreigners and international clientele, and especially from Europe that come to South Africa for substance abuse treatment. I'm saying that we have problems, but I can also say that access to treatment for historically disadvantaged communities in South Africa has changed, and it's improving, albeit slowly. The Secunda process, we have a procedure where we collect data on a 6-monthly basis. So it's from July to December or January to June. I'll speak about how that happens. We have regional reps in each of the provinces that would collect manual forms if there are, and these would be couriered back to Cape Town, which is our head office, the SAMRC's head office. Data is captured throughout the year and prepared for analysis. Analysis happens and data is analyzed for each province separately. So we do it for the country as a whole, but also for each of the provinces, and I'll share with you why we do that. And once the data is analyzed twice a year, we have biannual meetings in April and October in Cape Town, Port Elizabeth, Johannesburg, and Durban. And speakers are invited to share some of their own research, but at these biannual meetings, we share our data that we have collected through the Secunda network over a period of 6 months. So just in terms of data collection, that is our data collection form. So as I indicated, a treatment center, specialist substance abuse treatment center, would receive a batch of forms if they are still on the manualized version. It's a standardized 2-pager that is completed for each person or each patient that comes at first intake. And it basically looks at demographics, which is your gender, your age, education, etc. Then we look at the first and second substance of abuse, mode of use, frequency of use, age of first use, prior treatment, HIV testing in the past 12 months, because HIV is a concern in sub-Saharan Africa. And then, of course, referral sources of payment, types of treatment received. So data are collected two ways, either it's online or manually inputted. As I indicated, that would be manually. And then online is a platform that the MRC has created. So if a treatment center has the resources and Wi-Fi, they are able to input the patient details online, and those are available to us. We download it off the system. Hard copies are collected, but we also have a quality check for all our processes. So as indicated, just again, data is collected over January to June, July to December of every single year. The data goes through that process, and we have our feedback meetings. Then what we present at our meetings is for every province, because we feel that provinces need to be up to date and up to speed with what's happening in their selected area. We meet, and this is the kind of data that we would provide. So this is treatment demand data. It looks at the percentage of patients under 20 years that have been admitted to treatment. As you can see, I mean, we can stretch back, but the computer screen wouldn't be big enough. But it dates right back to 1996 if we were to input it. And as we can see across provinces, we have a large number of our patients coming into treatment are under the age of 20. Sometimes you see spikes, and that is for a drop or a joining of a new treatment center, which is an ongoing challenge that we unfortunately deal with. This slide looks at proportion of persons in treatment with heroin as their primary drug of abuse. Heroin has become, prior to 2009, things were very slow. As you can see, 2009 in the central region, we didn't really note, but our main concern is these spikes and this upward trend that we've seen the last period. Heroin was sitting at 36.4% of patients, and that's the northern region, and that's the region I mentioned where Niobe is quite prevalent. Methamphetamine, this is for data specifically for the Western Cape. As I indicated in one of the earlier slides, methamphetamine is not really that big of a problem in the upper north, but in the Western Cape and the Eastern Cape, it seems to be the drug of choice. Here we have primary. The blue is the prior where it's used as a primary substance. The gray is where it's used as a secondary substance, and this is overall. These two are joining, and it'll be interesting to see what happens now. But as you can see, 41.8% of persons admitted to treatment centers in the Western Cape specifically have methamphetamine as a primary substance or a secondary substance of abuse. This is just in terms of overall, when we look at secondary treatment data based on data from 9 provinces, primary and secondary substance of abuse, and this was for July to December 2016. And there, for the country as a whole, we see that cannabis, this is just treatment demand, so this is not prevalence data. It's just treatment demand, cannabis, alcohol that people seek treatment for, methamphetamine, over-the-counter prescription medication, Mandrax. Mandrax is our methiqualone problem, normally gets used as a secondary substance of abuse, and then cocaine. And I'll speak about that just in a minute. So how is our data disseminated? We have our regional meetings, which I'll get to in a little bit, which happens twice a year. I mentioned in April and October. We have reports and updates that I'll speak to. We have a website that is active. We have a lot of media requests and presentations that we do nationally and internationally on Sekendo, similar to what we are doing right now. These are just little pictures I put up of our biannual meetings that happen in the various provinces. And normally it's treatment practitioners, researchers, etc. that attend these meetings. And one thing I'd like to outline that our Sekendo meetings are not really just about sharing treatment demand data. As you can, this is just an example of some of our agendas. So you'll find that in every province, we would invite researchers to come and share their work so that practitioners, researchers, treatment specialists within an area get first-hand knowledge on what is new within a province. So for instance, in Cape Town, in April 2017, we had someone speak, or in Johannesburg, sorry, we had someone speak on attention deficit hyperactivity disorder amongst treatment-seeking adults with substance use disorder. We had someone speak on prevalence rates of fetal alcohol spectrum disorder, just to give you a sense of what Sekendo is. It's above and beyond just treatment demand. And normally at these meetings, we'd get notifications of new emerging problems that, or drugs that we would have to grapple with. In terms of our outputs for Sekendo, there are 3 outputs. It's our 2-pager. We have a full provincial report giving ideas of what is happening in each province. And then we have a condensed 18 version. These come out every 6 months. Included in the reports are a list of policy implications, issues to monitor, and research needs. And this is very important because it links to what we have over here. Because we are quite specific about policy implications, issues to monitor, research needs, we find that a lot of masters or potential masters and PhD students cotton on, and they would then do their research in these areas. And over the years, we've replicated in 11 countries in sub-Saharan Africa, some, and more recently Nigeria. My colleagues will be speaking later. However, some of the other countries have fallen off over the years due to their own challenges, and some of it is sometimes financial. We link specialist treatment center practitioners to policymakers and to research so that there's a better connect between the 3. Otherwise, researchers don't speak to treatment practitioners, and treatment practitioners have no connection with policymakers. And through Sekendo and our meetings, we try to bring people together, share latest research findings. We have 12 publications in peer-reviewed journals. We assist with the ARQ, which is the UN for the UN Global Drug Report. We've helped improve accessibility for all sectors of the community, because we can actually, through Sekendo, indicate to national government where the gaps are in terms of treatment services. We've aided our mini drug master plan, and we're also looking at service quality measures at present. This is just, it's a very bad slide, I can see, but just an idea of what goes into the reports that are disseminated. Advantages that we have, substance abuse and substance abuse and the need for treatment. This is what our system provides to us, emerging trends, and also assists in planning intervention strategies and ensuring services, making a case for services reaching communities. But we have also over the years, and it's been 21 years, strengthened local networks, capacity building, collaborations amongst researchers. We also are proud of the fact that we've provided a model for Africa that other African countries can draw on. And we use Sekendo to highlight policy, practice, issues to monitor, topics for further research. Our challenges: ensuring participation by all treatment centers. This is ongoing. Data collection is dependent mainly on the enthusiasm of individuals, and we really make effort to keep them enthused because there's no remuneration. And we have been talking over the years that Sekendo, government needs to institutionalize Sekendo and make it so that funding is better, and we could do more for ensuring continued participation. Changes in staff, That means lapses in data at times. Treatment center data may reflect admission policies and differential access to services based on socioeconomic status, and that I alluded to earlier. It's difficult to determine the extent to which findings reported in Sekendo can be extrapolated to the general population. We have funding challenges and difficulties in accessing ongoing data from other resources. I thought to, because I'm often asked to speak about the funding model. So currently, the Sekendo program is housed by the South African Medical Research Council, which is a national department that came about under an act of government. And one of the programs that we run as the Alcohol, Tobacco and Other Drug Research Unit is Sekendo. So our funding is mostly from the National Department of Health, and it's not a lot of money. And because it's not a lot of money, we have to cross-subsidize through the SAMRC just for our staff salaries. And our expenses, our overall project management is really where a lot of the money goes, including biannual meetings, because we travel to the various provinces, and then of course 20% to collation and dissemination. Thank you so much for listening to my presentation.
Great. Thank you very much. We really appreciate your comments. I think you gave us a lot of information about what you're doing in South Africa and some useful talking points as well about the current trends that you're seeing in South Africa. And we did get several questions come in, so I'm going to just read them out to you so you can have a chance to respond to our attendees. So the first question is from an attendee who was interested in getting more information about methamphetamine. And this question is regarding methamphetamine, the geography seems important. You have shown it as being principally in 3 regions. Is this a distribution availability issue or something else?
It could possibly be an availability issue. And I think what I failed to mention was South Africa is also a key transit point for a lot of the drugs, and they make their way through South Africa. And we suspect, and I'm not into criminology at this stage, but we suspect that, and we have had, just from our police data, a lot of clandestine laboratories that have been set up in Cape Town specifically being destroyed. But there's also comments and arguments about methamphetamine in relation to some of the other illicit markets, such as what we call paralamun, it would be abalone smuggling, and the interconnection between all of these. And if you can see, methamphetamine and where it features is really on the southern tip of the country, which is where the ports are. So it would be Port Elizabeth and Cape Town, and that is where a lot of methamphetamine cases are coming forward to treatment centers.
Okay, thank you very much for that information. Our next question is, could you speak to the sources of drugs such as heroin and meth? If it is coming across the border, where does the supply originate? And do you have a problem with illicit drugs entering the country along your extensive coastline versus a land route?
So heroin mostly comes in probably from the top of the country, from the north. Methamphetamine, as I indicated, we have a problem with laboratories, clandestine laboratories. So a lot of the what they get to make methamphetamine, they can obtain. And there has been moves, national government moves, really to ban certain of the substances that get used to make methamphetamine. So that's that ongoing problem. And then, of course, heroin just makes its way across the country and into South Africa from the north.
Okay, thank you. And our next question is, does data on drug-related mortality exist in South Africa?
Sadly, No, we are trying to get that going. We've had students and particularly PhD students try to delve into that. It is something that we flagged, and we hope to have over the next 5 years better mortality data. I mean, there's mortality data for other conditions, but not for alcohol and other drug use. We've actually had a student do a small study up in one of the provinces, and if I'm willing to share the data emerging out of that to whoever asked the question.
So is toxicology testing getting done, like your analyses, for instance, as a part of treatment programs or autopsies or that kind of thing?
They do, but they're not recorded necessarily. So yeah. So they do get done. It's just the problem is accessing all of that data, and it's not recorded necessarily all the time.
Okay. All right. Well, thank you. And the next question is about treatment, and it's from somebody who says, you noted that treatment funding is a combination of government and private money. Do users have to pay anything for treatment? Are there long waiting times for treatment?
Do users have to pay? We have two sorts of systems going here. We have the private funded treatment center, and we have the non-government, which is a non-government organization that would be rendering the service. So non-government organizations would receive a subsidy from what we have here, which is called the National Department of Social Development. They would provide an NGO with a subsidy to run a treatment program. Sometimes patients that seek treatment, they are first assessed to determine whether they can pay. If they can pay, it's often on a sliding scale. We do have in the Western Cape, and it's only in the Western Cape, it's what we call the matrix clinics. And the matrix, I'm sure some of the listeners would be aware of the matrix program. It gets run out of primary healthcare clinics in the Western Cape, and that is a free service because it is being paid for by the local government within the Western Cape, but it's unfortunately still defined to the Western Cape, although non-governmental organizations may have adopted the matrix model and be implementing that. And then of course patients would pay a sliding fee. Then we have our private funded treatment centers where you pay an arm and a leg at times for treatment. You can pay with medical aid, or I think some people would call it medical insurance, where you allowed a three-week visit to a privately funded treatment center for your condition. The argument whether that is sufficient, I don't know, but that is that. And then we have the upper end treatment centers that cater for your foreigners, and that is largely inaccessible to South Africans. It's a lot of money.
Okay, and we have one last question here from somebody who says, you mentioned that ADHD medicines are being used by students and working mothers. Do you know if these are being sold on the street, or are they primarily obtained from people with prescriptions?
It's prescriptions, and there's a whole culture of selling of if I get let's for example say I get a prescription for Ritalin, then I would share it, or I would sell it off to someone else. There's also a forgery, stealing of medical scripts, and then of course going to dodgy doctors. Unfortunately, we have some of those. And then unfortunately, we also have pharmacies that do not necessarily prescribe to the standards that would regulate prescription medications. So you would just pay for whatever, an antibiotic, or that is supposed to be a scheduled medication that you need a script for, you could get for just over the counter. And there is still concerns about these sort of pharmacies that exist. But it's a clandestine business. It's, like I say, you forge, you steal, you share, but there's always access somehow to the medications.
Okay, well, thank you very much. That's the end of our Q&A, and we really appreciate Dr. Burnhams, all the information you shared and taking the time to answer our attendees' questions. And so if you could stop sharing your screen now, I'm very pleased and excited to introduce our colleagues from Nigeria, Ms. Harsheth Virk and Dr. Ibanga Akanidomo, and we're going to turn things over to them now. So if you guys could remember to unmute yourselves and go ahead and pull up your presentation.
All right. Let me, am I on? Can you hear me?
Yes, I can hear you and we can see your presentation. So you just go down and start it. There you go. All right.
Okay, excellent. So yeah, hello from Lagos and to people in various parts of the world. Good afternoon, good evening. And thank you for including us from UNODC and from Nigeria in this global project of yours. So both my colleague, Dr. Ibanga Akan, and I are going to present. So I'm going to present half the presentation, focusing a little bit on the journey of how we got here. And Akan will talk about some of the findings, the analysis, and the challenges that we're facing. We in Nigeria are a very young system. We're barely, I think, I would say 2 years old. We're still at a pilot stage. We've learned a lot from the South African experience, and Nadine helped to start this here. But I'm going to talk a little bit about what UNODC is, the UN Office on Drugs and Crime, what we're doing in Nigeria, why we even have a mandate to be here. Talk a little bit about the aims of NENDU, which is a Nigerian Epidemiological Network on Drug Use, which is what we chose to call it in Nigeria, and the process of the questionnaire and how we arrived here, and which itself has been quite a long process. And then Akan will talk about the remaining 3 issues on the data collection and analysis, some of the key trends from the past 2 years that we are seeing. We've actually reduced the slides because of time, so I think he's going to focus mainly on 16 and briefly on the challenges. So before I get into UNODC, I'm going to talk a little bit about Nigeria. Nigeria is it is the largest country, I think, in West Africa in terms of population. It is the largest in West Africa and the largest maybe in Africa as well in terms of population. We are located in West Africa. It's the population is approximately 184 million people. A very young, very diverse population, over 250 ethnic groups. It is, I think, actually Africa's largest economy. I'm not sure what the current status is because of it's an oil-based economy, so I think we're in recession now, but it's still, I think, very competitive. But a bit like South Africa, still over 62% of Nigerians still live in extreme poverty. And I've also included some data on health expenditures and the density of physicians. As you can see, it's not that much considering what a wealthy country Nigeria is. So the health sector investment is not very high, and obviously this impacts on drug use and drug treatment as well. This data is not UN data. I've got this from the CIA fact sheets and the World Bank data. So a little bit on UNODC. So we are the United Nations Office on Drugs and Crime, and our mandate comes from the 3 international drug control treaties, the 61 Convention, the 71 Convention, and the 88 Convention. The 61 Convention is on narcotic drugs, 71 is on psychotropic substances, and the 88 Convention focuses on illicit trafficking. The international drug control system since 1961 has been unified under these 3 various bodies. The first is the International Narcotics Control Board, which also draws its mandate from the treaties. The Commission on Narcotic Drugs, where member states are members, and they govern the functions of UNODC. We're based in Vienna, but that's where our headquarters is. So we have 3 main pillars of work. We work on illicit drugs, we work on crime and terrorism and explore the links between these. But our work is focused on normative work linked to the treaties, also research and analytical work. I think Nadine mentioned the World Drug Report. where member states contribute to the annual research questionnaire ARQs, and then field-based technical projects, which is why we're here in Nigeria to help to work with the government here. So in Nigeria, we are funded by the European Union, a very well-funded project, which is quite rare in the UN. So we have a good amount of money, a good amount of time to hopefully make an impact here. The objective is to support Nigeria's efforts in fighting drug trafficking, preventing drug use, and curbing organized crime. We started in 2013, and it's going to continue till 2019. So the project has three main outcomes. The first one focuses on research. We are actually doing a national household survey in Nigeria. We've completed that, and a community-based survey. We expect to have results available by, I would say, March next year. So we should be able to get an idea of the number of drug users, drug use patterns in, at the national level and per state as well, which I think is going to be, obviously it will have a huge impact, hopefully on policy as well. The second component focuses on law enforcement responses, working a lot with law enforcement agencies to strengthen, anti-trafficking, etc. And the third outcome is on drug demand reduction, which is focusing on drug prevention, treatment, and care. Under that, one of the outputs is to help Nigeria on their routine data collection and case management for drug treatment. So that's a little bit about who we are, why we're here, what our mandate is, and a very brief snapshot of Nigeria. What is NENDU? So when we started the project, we did a couple of assessments, and actually Nadine and the MRC helped us with this. We ran a workshop of some of the key players in Nigeria, which is the National Drug Law Enforcement Agency, which has a mandate to provide counseling services, the Ministry of Health, which has specialized hospitals, which provide drug treatment, vis-a-vis psychiatric and teaching hospitals. What we found is the data collection on illicit drug use generally is fragmented in Nigeria. There was no single institution that collected data in any systematic way. There was, within drug treatment centers, there was some amount of data collection that took place, but mainly more like patient data when patients were coming in for registration, but there was no standardization. The NDLEA also had its own data collection forms and formats, but there wasn't much standardization, and there wasn't any linkage between the health sector and the law enforcement sector. By law, the National Health Act gives the Ministry of Health the mandate for collection and analysis, which gave us a basis then of which agencies to work with and how to take this forward. Based on this assessment, we had a workshop. I won't get into the details. We had a 2 or 3 day workshop which was facilitated actually by Nadine and her colleagues from Sekendu, where we examined what the current situation is and what we want to do to improve it. And based on that, we came up with this. We christened this network called the Nigerian Epidemiological Network on Drug Use. And the aim, we decided, would be to monitor treatment demand and trends in drug use. There was some talk of maybe expanding it to go more into drug law enforcement data, etc. But we felt it was a little too ambitious right now, because we really didn't have even a simple system where we could collate all data from Nigeria together. So the idea was to provide information on people who enter treatment and specialized treatment services. This could be in hospitals under the Ministry of Health, or in the National Drug Law Enforcement Agency, where people come in for counseling, which is low threshold treatment services. We want to obviously eventually, like South Africa, include NGOs and include the private sector. But this might be something that the government might need to take on beyond what UNODC is doing when the project ends. We wanted to get information on the number of people who initiate treatment for their drug use, the characteristics and profile of these people, and the drug consumption patterns that we are seeing. The main aim was to inform policymakers within Nigeria, but hopefully including the ECOWAS, the Western African Community, and the African Union, for development of adequate drug responses and treatment systems, but also to help Nigeria in their international reporting obligations under the ARQ, which I think the previous speaker also mentioned, but also on the African Union and ECOWAS, which Nigeria has to report on. I'll talk briefly about the questionnaire, and then I'll hand over to Akan. So we developed at this workshop a draft data collection format. This was adapted from the West African Network on Drug Use and of course the South African one, which has been tried and tested. In fact, the West African questionnaire is also based on the South African one, but we made our own changes within Nigeria depending on what the doctors wanted, what the government felt was required. We've tested this questionnaire now for 18 months, and by the middle of 2016, it was finalized. The big change that was made was that when we started data collection, we had this concept of the drug that causes the most problem, which was self-reported. So the patient himself or herself would say, this is the drug that causes me the most problem. But over time, we felt it wasn't giving the correct picture. So this was changed to this concept of the primary drug use, which is the concept identified as the most problematic drug as identified by the physician, which is now also in line with international standards and the EMCDDA, etc. So the form is a standardized form. It's filled per client like Sekendo. It has a total of 28 questions. I think we're a bit longer than the South African one. 3 main areas: treatment demand indicator, which looks at the type of center, type of admission. We do have a lot of involuntary admission in Nigeria still, but mainly this is not court ordered, but mainly to do with pressure from families that you have to go in for treatment. And the type of treatment as well. This is counseling, detoxification, rehabilitation, etc. We look at social demographic information and then drug-related information on the types of drugs, primary, secondary, route of administration, frequency of use, etc., polydrug use, HIV, hepatitis. And in Nigeria, we also look at other health issues which are linked to drug use. So this data form is basically it focuses on treatment demand. It's in line with the European system, but we're a European Union funded project, of course, but also that the UNODC also recommends the EMCDDA form. And so we wanted to be in line with that, as well as with our own reporting obligations within Africa. So the difference is that the Nigerian one counts all treatment episodes, but we can also, like the European one, but we can also count, we have the means to count the number of patients because we have a unique patient ID as well. Well, it's a very new system right now, so we'll have to see 4 or 5 years down the line how this works, but we're starting to see that we have the capability to do that. The differences I've outlined, and the other big difference in Nigeria is that we do count alcohol as a primary drug and tobacco is secondary. And in the European system, alcohol and tobacco are not counted as primary drugs. So that's it in the first 3 bits. I don't know if Akan's ready. I'm going to close mine and hand over to you. Is that okay?
That's okay.
All right.
Okay, just to take a cue from where my colleague left off in terms of the NANDU process in Nigeria, we have been collecting the data since 2015. We have collected it from 11 centers. What happened in Nigeria, wide as it is, was that we, through recommendation, had selected and worked with 11 model treatment centers. And so they started, they're the ones in blue that you're seeing. And they have various capacities from 4 beds to 80 beds. So they started collecting data on in 2015, January. What we have done is 31st of December of each year. And what you then see, it's basically divided conveniently into 6 different zones. And so we had approximately 2 model centers in each of these zones. Again, to help us get a somewhat better picture of what is happening across the country. In 2016 of law enforcement agency. They are also mandated to do treatment, and therefore they were collecting the data also. So there's 7 centers that were included as pilot centers from these organizations. And so this has a mandate to house the data, and what UNODC at the moment, and because of the existence of the project currently, is the one doing the data validation and analysis and reporting. So you have about 18 centers that are sending in this information to the Federal Ministry of Education. So what we've done is to yearly collate this data and then report back to the different bodies, the coordinating body, to brief members of the policy-making body, but that is not set in a way that is routine at the moment in terms of influencing policy. But we do share this data in that way, hoping that it will begin to form part of the policy drift, okay? We're hoping also to eventually hand over this process of data analysis and validation to the Federal Ministry of Health. And currently we're setting in place the structures that would make it possible for us to fully hand over these responsibilities to that ministry. So in terms of what we found in these analysis, remember it's from the 1st of January to the 31st of December of each month, and then it's from the 11 model treatment centers. That was from the first year. But from October 2016 is when we then entered the second group of settings or treatment facilities. So the data is submitted to the Federal Ministry of Health. They then submit it to us. We then, in UNODC, we then collate it and analyze it and report. So in 2016, as my colleague mentioned, we have the capacity to measure both the number of clients that are entering into treatment as well as the number of treatment episodes. What we did find that year was that we did have 990 patients that did enter into treatment, but 991 episodes, meaning that one client, one patient actually had 2 episodes of treatment. Now, among the 2016, again, we did, part of what allows us to do that is that we had allocated an NENDU code that is peculiar to each individual. So if he was to go to any treatment facility across the country, he would still have that same code. So that would allow us to track that patient over time. Now, among the patients that were admitted, we found that there was a large percentage of males, 94.8% as opposed to females. So in some cases, you had 1 to 98 or 2 to 1 to 50, depending on the facility you were looking at. The median age for patients was 28 years old. A majority of them came from stable accommodation, and this probably might be reflective of the fact that a lot of them are brought by family, and again, because of the cost of treatment having to be borne by family, you'll find that many of them would come from stable living conditions. Again, a lot of them are from the urban area, 59%, or semi-urban areas. Close to 18% was single, and we found only 2 of these clients that reported for treatment were actually foreign nationals. In terms of the substances of abuse that was seen, this looks at the data of 2016, where 968 were the validated questionnaires that came in. we find that largely it was of cannabis and the opiates. This was 47% and opiate behind for the treatment. When it came to opiates, when broken down, it wasn't largely heroin or morphine. It was more or less the prescriptive for opiates. It was tramadol and codeine misuse, as well as pentazocine. That formed the major bulk of the opiates that was being abused or used within these patients. Now, so you find out 53% of those who entered the treatment from May 2016 were reported in terms of polydrug use. When you look at it in greater detail, the polydrug use was higher among those that use cocaine or crack cocaine or ATS. Also, you find with alcohol being the primary drug users of alcohol are mainly using tobacco as a secondary drug and less often cannabis. Whereas when the primary drug was cannabis, you find that they were frequently using alcohol and tobacco, but to a lesser extent, the opiates. Again, with crack cocaine, the secondary drug was cannabis and opiates. There were few patients that indicated lifetime use of injectables, and we had 6%. Among these, primary drug of use was opiates, and 79% of them had never shared in the equipment. Now, when you look at the data between 2015 and 2016, there were slight differences. There was a drop in terms of the total number of patients that did enter into treatment. But again, we find that in 2016, we did add that one facility, which was NDLEA, to be reporting. In comparing, in the first year was when we had 1,400 treatment episodes in 2015 and 928 in 2016. So there was a 10% drop. What we have seen as a possible cause or attribute mainly to this is the strikes that were being experienced in the country in the hospitals at that time. So there were periods where the doctors or the healthcare workers went on strike, and what they did during that period was then to discharge clients, and when resuming it was a gradual process for clients to return and for new clients to be taken in. So this could be what was responsible for this 10% drop that we have reported here. This gives you some kind of a picture in terms of comparison between the 2 years in terms of and in 2016, the primary drug as reported by the doctor. You find, again, the changes in alcohol not being, tobacco not being a primary drug of use. So you see largely still the opiates and the cannabis, both here. Now, in terms of the challenges that we have seen, one is having a buy-in of NENDU in the Federal Ministry of Health. First of all, this is because the institution didn't really have a department it could sit in. But currently that has been set up, and there's a department that has been created to now handle that. And so it is, it's gradual that there'll be a pickup, but there's an institutional backing now to be able to actually take up this responsibility of housing and running the NENDU. Again, we have, it's a large or very large country. We're only piloting with a few of the centers, and there'll be a need to increase it to other centers within the country, as well as other types of facilities that are actually doing treatment, like the civil society organizations that do exist. Again, there's limited capacity that exists in terms of data validation, data entry, and analysis. And we are looking into this in terms of how to build capacity in that area before the end of the project in 2019. So what our next steps actually are is to look at this in terms of sustainability of the NENDU project. So we're going through the process of trying to iron out how to officially hand this over and have it running through the Federal Ministry of Education. We are committed to continue to build their capacity to do this, both in terms of collating the data, analyzing, and then disseminating the results. And again, linking this with the policy organs within the country. So that brings us on, gives us a kind of picture in terms of where we are for the NENDU within Nigeria. So thank you.
Okay, thank you very much for that presentation about Nigeria and what you're doing there. We did have a little bit of trouble with the noise. Dr. Akanidomo, when you were speaking, you broke up a little bit, but we will have the recording of the webinar on our website, and we will also have the slides available. So if anyone missed anything, hopefully you will be able to pick it up there. And we did have one question come in, which I will pass along now, and that is regarding need for treatment in a population of 186 million, but only 990 patients in treatment in 2016. Do you have any idea how many people are not receiving any help with addiction?
Well, you could say what the people that actually enter into treatment is a drop in the bucket. And that is because—
Can you speak up a little bit so we can hear you? Lean forward.
Yeah, we do have, you could say it's a drop in the bucket. The facilities we have in Nigeria are very limited. There probably is one facility in each of the 36 states. And as you could see, the largest one was 80 bed, but on the average you see 10, 15, 20 bed hospitals, and that's to serve a state. And so you find out that access to treatment is an issue here. So that could be a major reflection as to why we have such small numbers in treatment at the moment. And again, this is just, as I said, we're just reporting from a few of the centers at the moment.
Okay, thank you very much. And that's the only question that we got in today. And so we're going to go ahead and move on. So if you could stop sharing your screen. Thank you. And then I will bring this one back up again, just to remind everyone who we were fortunate to hear from today. And I want to just thank you all again for participating with us today, and we look forward to continuing our collaboration with you and moving forward with the GDUS project. And before I let everyone go, I want to just launch a brief poll, and I would appreciate if you could just take a couple minutes to answer a few questions for us so we can get some ideas of what other topics you might be interested in. And I also want to just fill you in on our upcoming webinars. We're currently planning several webinars, which will be featuring experts from our NDU Sentinel sites talking about the results of their new reports, which will come out later this year, and also experts from the University of Maryland Center for the Advanced Study of Language, who will be presenting on a new article that they are having published on their results from some analyses they've been doing of Twitter. And additional information about these webinars and any additional sessions we may do as a part of GDUS will be posted on the NDUS network and on the NDUS website, which is, again, is www.ndus.org. And that will also be where we will post complete recording of this webinar and copies of all of our presenters' slides. So again, thank you for your participation. And David, do you have any closing comments you'd like to share?
I'd just like to thank sincerely our presenters. And we've had two very interesting views from two very different jurisdictions with their different levels and different stages of development. So thank you very much, and look forward to working together on work on developing the further resources. So thank you and good morning.
All right. Thanks again, everyone. We really appreciate you joining us today, and we hope to see you again in our next session.
Bye.
All right. Bye, everyone.
Bye.